Hello, everyone. This is Liz Venuto, the supervisor of the Children, Youth, and Family team here at the Healthcare Authority. If there are any difficulties hearing us, please do send in information through the chat box. We're happy to address that. Today, we are here to talk about Adolescent Behavioral Healthcare Act, House Bill 1874. We are hosting today, but this PowerPoint was produced and is being presented by Kathy Brewer from Seattle Children's Hospital and Peggy Dolane, a parent advocate in the community. This is a beautiful partnership, and you're going to get a lot of information here today. We're going to pause after various sections so that there are opportunities to ask questions. There will be more information coming. We have received a lot of questions, so we'll be updating our frequently asked questions after this. We will be posting this webinar to the Children's Mental Health Workgroup page, to the Children's Behavioral Health page, and distributing it. If anyone has any requests for it, you can send it to our inbox at HCA Family Initiated Treatment at hca.wad.gov. The updated mental health treatment options for minors form is being finalized, and we'll be able to distribute that next week. So those are just some more things to come. There are 2 handouts that you can take a look at as we move forward. With all that being said, I'm going to pass this over to our presenters, Kathy and Peggy.
Welcome. I hope everyone can hear us. If we got any responses from people that are out there, it'd be nice to know that there's people listening.
Yes, could we get a hand raise or a chat or something if you can hear us?
Yeah, just to make sure that we're actually broadcasting.
That is an excellent idea.
Can we unmute and see if people are able to?
It is on, not on mute. It's on mute.
No, the audience is on mute.
It's under her.
All right, we're checking to see if people can hear us, and we're waiting for hands to be raised. It doesn't look like we're getting any hands raised. Can you unmute the audience and let them speak? Because right now they are muted and they can't say anything. Is that their audio?
All right.
There's people raising their hands.
Oh, we're seeing hands. Excellent.
Okay.
Thank you all. And we also think we just managed to mute, unmute all, so we should be able to have some conversation after this. So thank you for letting us know you can hear us.
Great. So I will keep going as to venture forward, just to say hello, and Kathy and I are really thrilled to be here and presenting this information. It's been a long time coming. Let Kathy just say hi for a second.
Hi, this is Kathy Brewer. I'll be talking later.
Great. We always have to have the disclaimer that need to consult attorneys if you're a clinician. And I don't believe the RCW has been posted yet. I heard that it was going to be posted at the end of this month, and I haven't checked, but that is an issue.
I can confirm I don't believe it has been posted yet, but I think that is also being finalized.
Right, but the law did go into effect on July 28th, so this is relevant information. We're going to go over, this is a really complicated subject, so we're going to go through the background of how we got here, some definitions we're going to be using today. The big 2 parts of this will be who can consent and what are information sharing procedures, and then we're going to talk about some information about perspective of parents and perspective of clinicians on how to work this. Our presentation goals is to learn about what we're calling the Adolescent Behavioral Healthcare Access Act. Yes, parts of it are FIT, Family-Initiated Treatment, and Adolescent-Initiated Treatment, but really we're talking about adolescent behavioral healthcare access overall, and how families involved can help their kids when they're struggling. We're also wanting to share information about the new law about confidentiality and information sharing. It's quite complex, and we'll dig into that in greater detail. And now my down button's not working. Nope, you're off on, you need to click on the presentation, and now I can go down. Yes. Now? Yeah, okay. So there is, as probably people know, there's an increased mental health need for adolescents in Washington and the United States. There's huge increase in suicide attempts and deaths by suicide, as well as other kinds of problems that youth are having, the opioid epidemic, for example. And that there's a lot of research that shows that parents and families are vital partners in helping adolescents participate and access treatment. And so we're moving towards a system that allows us to do that. The new legislation will also change how providers evaluate and treat adolescents, because it allows greater collaboration and access to information with parents and family members. And once again, this is going to be a problem because, yeah, got to keep keeping the there. Okay, so gaps in parent-initiated treatment is, there's a bunch. And I think most people out there know that it was only providing short-term stabilization through hospitalization, and it did not allow outpatient treatment access by parents, even though parent-initiated treatment allowed for an adolescent to be evaluated in an outpatient setting, but a parent couldn't get the information unless the adolescent was consenting. So it really didn't have very much use by anybody. We also know that there are adults that are caring for adolescents that are not technically parents, but they may be other concerned adult or family member. We'll talk about the definition of that we are expanding to include other people. And that we're also, parents have really, and caregivers have really not been able to collaborate in their adolescents' care, and this law is an attempt to move towards family-centered treatment and giving parents that ability to really be part of the solution. So in 2018, last summer, we had a work group of 21 sessions that Kathy and I were really involved in. It was formed out of a legislature work group of House Bill 2779. And we developed the recommendations and had consensus that led to House Bill 1874. And it was passed in the legislature unanimously by the Senate, and only 8 votes against it in the House, which is pretty darn amazing. Going into effect, like I said, July 28th. So the overall objective of the bill is to obviously increase access to behavioral health services for adolescents 13 to 17. The essence is we amended minor-initiated treatment, we expanded parent-initiated treatment, we modified providers' notice obligations for hospitals admitting under family-initiated treatment, and we clarified providers' authority and discretion to share adolescent mental health information with family members and caregivers. And there are a lot of caveats, and I'm sure there are people that have a lot of questions at this point, and we will have breaks to talk about these issues after we've gone over some of the complexity. So this model is coming from our statewide FISPER model of family, youth, and system stakeholders, and thinking about things that you can have youth accessing treatment without their parents knowing, and parents be able to access treatment. That's dialectical thinking, is that both can be true. We don't have to have either or thinking, but we can have both and thinking. And even things that can feel competing with each other or in conflict, we can still hold both of those truths and navigate our way through it. And it makes it's a little more complicated and difficult, but the end result is modeling some behavior that families need to navigate conflict. Is sometimes there isn't one right way, and we have to figure out how to help families through that. So adolescents can still access services confidentially. That's super important because we're expanding mental health care into schools, and we don't want to have a provider call, your son is here and is really upset, and can we talk to him? And no. I mean, we just want the child to be able to access care right away and not have to go through that step. And we also want to guard against needless hospitalization and deprivations of liberty. So responding to clinical needs, which we have not been able to do because in the past, sometimes because we know there's a clinical need, but the child is not capable of consenting because of various challenges. Now we'll be able to get that child help. So we are looking to transform our system to whole family treatment. We know that Kathy will say, and it's steal your line, that she sees a child 1 hour a week, and the rest of the time the child's living in the family home or at school. So focusing on whole family treatment is the best practices for getting help, effective help for adolescents. And there are a variety of ways for adolescents now to access behavioral health, which is great. We want parents, youth, and clinicians to work as partners, not as adversaries. And part of that is evolving our thinking about how families and parents are part of the solution, especially when children are living with their parents. That if you don't work with a family member, the situation that the adolescent is struggling with may not change. And so the effort is for naught, or only half the solution. So quickly going through some definitions. These are not legal, well, a couple of them have legal ramifications, but mostly they're definitions that we're using here in this presentation. So adolescent is a new definition in the law that is a minor between the ages of 13 and 17. A minor is any child under the age of 18. So we're specifically targeting adolescents of children aged 13 to 17. The parent caregiver is an adult authorized to make healthcare decisions for the adolescent, which is obvious when you're a parent, but it also includes parents being able to give a signed authorization to make healthcare decisions for an adolescent. That sometimes, like, parents do that when your child goes to camp or to school, and you sign off that the person taking care of the child while they're under their care, they can, if you needed to go into the hospital, they could provide authorization for that child receiving services. That's similar here. Step parents for the first time are being included on being able to make these, bringing the child to a treatment provider, and oftentimes the step parent is serving as, a parent, even though, from the legal standpoint, they aren't considered fully a parent, but they're taking care of the child as if they are. So giving that parent the authority to make those decisions and to have the information is really key. Same with kinship caregivers and any other relative who's responsible for healthcare of the adolescent. And there is already, this is a standard that we have within our CW, that being able to, if you're able to declare under penalty of perjury that you are a relative responsible for the healthcare of the adolescent, then you're able to act as a parent in this case. We have 2 slides of the same thing. Medical necessity. This is a definition that is out of the RCW. And I'll let people read that because I want to just keep going through to the key changes in the law. But it's important to note that medical necessity is often perceived differently by the parent, the child, the school, and the payers. And being able to have open conversations about that is a super important thing that this bill allows. So there are a whole bunch of different kinds of outpatient treatment that now our parents are parent caregivers to encompass all those different roles. Parent caregivers are able to consent for, including routine outpatient, intensive outpatient, partial hospitalization, and WISE. And we will talk further about what that means. Acute inpatient, and there's a definition of inpatient. You guys can read that later. There's also, Hippo is really important to understand, especially in terms of psychotherapy notes, because there's a lot of different understanding of what a psychotherapy note is among the clinical providers, and Kathy can talk a little bit more about that later on in her presentation. We also need to take into consideration 42 CFR Part 2, which is a federal law governing the privacy of substance abuse treatment. No information may be shared about substance abuse treatment with anyone of any age, in any age group, without the client consent. That's a federal law that supersedes any state laws. So if a child is in co-occurring treatment, that has 42 CFR requirements for information sharing. We'll get into that in a little more depth as we get along. All right, access and consent. All right, so there are basically 3 ways under the new law that parents or that adolescents can access treatment. One is on their own, adolescent access-initiated treatment. There's parent caregiver, which is family-initiated treatment, and then there's involuntary treatment, which we're not going to talk a lot about today, but we are, at least including that in our process. Involuntary treatment is not being changed. So adolescent-initiated treatment has both outpatient and inpatient capacity now that parents can consent for outpatient or inpatient care. And the provider needs to determine whether they are able to do the treatment, the capacity, and whether it's medically necessary for outpatient and inpatient. So just because a parent says, I want my child to have treatment, the provider needs to decide whether that treatment is necessary. And I'm wondering if we can cover up the edge of the slide somehow, because it's kind of, there you go. All right, and then click on the slide so I can go next. See, I just did that. All right, so family-initiated treatment also has 2 pathways. So basically going back to the previous slide, which, where are we? Adolescent-initiated treatment. So the adolescent is accessing care individually. I'm sorry, I got mixed up because I was not able to, I was distracted by how our slides were looking at this end. So adolescent-initiated treatment, again, the youth it's unlikely the youth is going to go and not have a problem. So I think this is the way it's currently working, and it will continue to currently work the same way. With family-initiated treatment now, families for the first time have ability to consent for outpatient treatment. So the parent and provider need to agree that it's needed. The provider has to agree that they have the capacity to treat. And for routine outpatient treatment like counseling, it's limited to 12 sessions over 3 months. Inpatient is the same. The provider needs to agree that treatment is necessary and has the capacity for inpatient treatment. And there's a number of safeguards in that process. So it's really important to hear that there's no obligation that a provider has to treat an adolescent under family-initiated treatment. The providers hold on to discretion about whether a child needs the treatment or not, and whether they're appropriate, whether they have the skills or background to do that treatment, or if they have the room. They're not obligated to take an adolescent just because a family wants them to, or even if the adolescent goes independently. That's provider discretion. However, just because an adolescent has not consented to treatment is not a reason to refuse that child for treatment anymore. So previously, with the old law last month, a provider could say that, the child is saying, no, I don't want to do this, and that was it. There was no recourse for a parent. Now it's just because the adolescent is saying no, that's not the only reason for refusing. You need to not have the room in your caseload. You may think it's not medically necessary, or it's not your expertise. But it's not the sole reason for saying I'm not going to take that patient. And of course, medical necessity is always the key question that we need to be asking about whether they need this treatment or not. So back to routine outpatient treatment under family-initiated treatment, there's a limit, like I mentioned, which is up to 12 sessions over 3 months, whichever comes first. And there's no limit to the number of different clinicians a parent could bring their child to. This sometimes concerns people, like what if parents get Munchausen by proxy in the mental health world? I would hope that a provider would, as part of intake, ask, what other services have you used? And, oh, that one didn't work. What was the issues with it? That's part of the process of onboarding a new client. And so it should be addressed there, that if the child didn't think it was something they needed and that's why they didn't want to consent, then that's the number one issue that needs to be addressed, is why does the parent think this is needed and the child doesn't? We want the adolescent to consent to care over time, but we do recognize that a lot of kids right up front will say no. They're not going to say yes. They need time to build trust and rapport with the provider. Okay, intensive outpatient and partial hospitalization is also covered. The adolescent can consent to those treatments as well, but the parent caregiver can consent even if the adolescent doesn't. There are reviews of, if it's an inpatient mental health facility, there's a review with a treatment team required every 30 days to assess medical necessity. Now, again, we're talking about review of records or medical necessity is important, but if the child has a substance abuse disorder, we have to get the child's consent to share that information with anybody. So it could mean that the review is not going to happen if the adolescent's not providing consent. It's really important that providers have protections against liability, both so that there is no cause of action by an adolescent against the provider facility based solely on the fact that the adolescent did not consent. There are additional provider protections under inpatient treatment as well, and those are already in existence. We did hear that there was reasons that providers were worried that they were going to be sued if they admitted a child to inpatient treatment, so that clause was super important to encourage access to care. Involuntary treatment has a process, and then we're including in here so you can see it. There's a lot more information and people that are handling and using this process. This is mostly that for parents to be able to see providers. That has not changed. All right, information sharing. This is you, right?
Yeah, and I think we're going to pause for a moment and see if there's questions about what we just covered on access and consent before we move on to information sharing. So if people want to, we're going to open up the mute, or are we going to have chat questions?
It's unmuted.
It's unmuted, okay. Questions?
So this is Liz. I unmuted for questions. We do have quite a few attendees, so if we get too many at once, we'll filter them through the chat box. But for now, if you do have any questions about what you've heard so far, feel free to speak up.
Maybe we should call people that have their hands raised.
I think their hands are raised because we asked them if they could hear us.
Oh,
right.
Yeah.
But I can take those off. Anyone, do feel free to raise your hand if you have any questions too. We are removing the, oh. There you go. Jody, do you have a question for us?
Everyone's muted.
Oh, they're still muted.
Yeah, unmute that whole thing.
So at the bottom there with all. Okay.
All right, you're unmuted now.
Maybe. Why do they look muted still?
Oh, there we go. So someone unmuted. We hear a little background noise. Do you have a question?
Hi, I'm going to try asking a question. Can you hear me?
Thank you. Yes, we can.
I have been looking through the law and trying to untangle all of this stuff, and it looked like the language in the law said that inpatient providers couldn't solely refuse treatment based off of the adolescent's consent. Is that true for inpatient and outpatient? so that if an adolescent comes and I'm an outpatient and they're like, I don't want to do it, and that's the only reason I wouldn't take them, am I still supposed to try? Thank you. I'll disconnect and let you answer.
Yeah, that's correct. So inpatient care has always been an option under what was formerly called parent-initiated treatment, and lots of times teens are admitted under what's now called family-initiated treatment, so that hasn't changed. But now as an outpatient provider, if you start to go through your regular consenting process and the adolescent says they don't want to consent, they don't want to sign your form, you can say that's okay. I'm going to go ahead and have your parent sign today, and let's just continue. And then you just make it as smooth as possible to start to do the clinical work that you need to do. And then at some point prior to 12 sessions or a 3-month period, you would want to go back to that consent form and just, maybe when they're more comfortable with treatment and say, hey, remember this form we talked about, several months ago? I do need, it's time to sign it. Let's go ahead and have you sign it just so we have your consent. And, hopefully at that point, the adolescent will be engaged and on board and it won't be a big deal. But you don't have to kind of halt your effort right in the beginning if they refuse to sign. You just need to make sure that you have a parent that falls under the definitions that we described that can sign on behalf of the adolescent.
Thank you. That makes a lot of sense.
Great. Anyone else want to ask a question at this point? Okay, let's continue. Okay, we will stop again for questions later. So this is Kathy Brewer, and I'm going to talk about the information sharing components that have changed as a result of this law. And so the first thing I'm going to talk about is what hasn't changed. And for substance use evaluation or treatment, the federal law 42 CFR Part 2 still applies. So on the work group that Peggy and I were on, we had hoped somehow that we might be able to make some inroads in this, and then healthcare authority folks and legal folks were able to clarify that no, that our state law cannot override this federal law. So you may only release information about the substance use evaluation or treatment with the written consent of the adolescent receiving the treatment. As a provider, if you do have written authorization from the adolescent, but you are concerned that sharing information would be detrimental, you have discretion not to release the information. So authorization is required, but it doesn't mandate you to share that information. You still have some discretion to decide what pieces of information are appropriate to share with a parent or guardian. And there is a new part of the law, so our state law can add on to and kind of link up to 42 CFR. So there is a protection in place for substance use treatment providers that you won't be liable for the decision to disclose or not to disclose as long as you have the written authorization of the adolescent. And so if you, again, choose not to disclose information, even with the adolescent's consent, you would want to make sure that you document that and maybe get some consultation from a colleague to make sure that you're reaching that decision in what we would call good faith and without gross negligence, which are legal terms that I don't entirely understand, but I think as long as you get consultation, you're in pretty good shape usually, and you've documented. So now there are some big changes for adolescent-initiated treatment. This is when the adolescent is consenting, and the law that we've been living under prior to July 28th. And we are allowed now to talk to parents. However, for mental health services, the new law says that providers should not proactively release information to a parent unless there is an imminent threat of health or safety. So if there's a danger to self or others, you would need to proactively. That means without consulting with the adolescent first. You should only do that when there's danger to self or others or as otherwise required by law. And we'll talk about what comes next if it's not a danger situation. And then for substance use disorder, including co-occurring treatment, you, again, may only share information if the adolescent provides written authorization. So for adolescent-initiated treatment, if you want to share information with a parent, which I think most providers will want to share some information with a parent for good care, you have to talk to the adolescent first. So again, you can't proactively do it without talking to them, to give them advance notice,
you give them an opportunity to share their concerns, and then you use your discretion based on that parent-child family configuration to decide what you're going to share. And then you document that you had talked to the adolescent, they shared their concerns, you went ahead and decided to share X information with the parents. You're going to put that all in your medical records. So you are allowed to talk to parents after talking with the adolescent and giving them a chance to share their concerns. That is a new process for all of us. And here's an example that I wrote up that I think we need to make it part of routine treatment. So this is something that folks I work with, the kinds of things that we might say. When I work with teens and families, it's important for me to talk to their parents about diagnosis and other issues, what we're doing in treatment, so they can be helpful. So then you say to the teen, I'm going to check with you first to see if you have any concerns. If you do, we'll talk about them. And then here's the type of information that I typically share. So we have an example at Children's Hospital where I work. We made up a flyer that we're going to use when we first meet with a patient that gives examples of what we're going to share with the parent. So the adolescent knows that we're not going to share everything, that they can trust us with information that might be sensitive that they really don't want their parent to know. And we agree, probably the parent doesn't need to know. And I think we have some examples of that information later in the presentation, and also we'll have access to a flyer that you all are welcome to use if you want to modify the language to fit for your practice. It's just a different kind of communication around consent and information sharing, which is part of kind of our typical disclosure process when we have to go through that process with a new patient. So for release of information for family-initiated treatment, again, we are able to, as providers, we're able to share information. And the difference here is that providers are encouraged to release information and records if it would assist the parent in understanding the nature of evaluation or treatment. You are not required to first check with the adolescent, identify their concerns, decide what you're going to do either. You are encouraged to release information and records. I will say for myself, I think that from an engagement standpoint, I probably would talk to the teen anyway if I wasn't, delaying treatment in some way by not talking with the parents, because again, we want to engage youth into treatment regardless of how they get there. Adolescent initiated, family initiated. The goal of a therapist is we're most effective if we can engage the youth. But nonetheless, you don't have to talk first to the adolescent to feel comfortable releasing information to the parent. I'm going to talk about psychotherapy in a minute. For family-initiated treatment for substance use disorders, including co-occurring, same rules. You cannot share information or records with the parent if the adolescent does not provide written authorization. So really briefly about psychotherapy, and this is back on slide 18. So Hippo has a very unique definition of psychotherapy, which may not match all of your practices for those of you that are providers. HIPAA says that psychotherapy notes are the notes that a provider would take, documenting, analyzing contents of a conversation that are separate from the rest of the patient's medical record. And those separate notes are really considered to be primarily for personal use by the treating professional and are generally not disclosed. So for me, this sounds like someone that might do like a psychoanalytical practice where they have these kind of separate process notes to keep for those psychotherapy sessions. The kind of psychotherapy that we provide where I work, and that I think probably most of you provide, we don't keep a separate chart like that. All of our information is in our medical records. So even though the service is called psychotherapy, the procedure code that we build is called psychotherapy, it does not match the HIPAA definition of psychotherapy. So I think it's very important for you all to take a look at your practice. If you're meeting the HIPAA definition of psychotherapy, get legal consultation as you need to. But basically, if it's part of the legal medical record, if the psychotherapy session is part of your legal medical record, then it does not meet the HIPAA definition. And so just be aware of that. Now, does that mean I would share my psychotherapy notes? Probably not. Unless it's really useful, but I can share information that comes out of a psychotherapy session if I think it's relevant. So you still have clinician discretion. So back to slide 37. For adolescents that are receiving care with your parent-only consent under family-initiated treatment, you're encouraged to release information that would be either verbally or through records that's necessary to assist the parent in understanding what's going on with their adolescent and how they can help them. So that's really the goal. We want to engage parents and caregivers in helping their youth get better, and that's what we have to talk to youth about. That's why we talk to parents and caregivers. They live with them. They are there with them much more than we therapists are, and so we need to engage the family as a whole. At the same time, as Peggy mentioned earlier, that dialectic, we also want to have adolescents have confidentiality in treatment. We know that that's what helps them really engage and to develop that trust. So as providers, this makes us have to decide what is the right information, and I think we all know that it'll be different for every patient, youth, and family. That you might have some families you share more information with or less, and it'll be part of a conversation with that youth depending on their relationship with their caregivers, the trust with them, the ability of the caregivers to really engage with treatment. All of that is part of clinician discretion. So providers are not mandated to share. You, as a provider, can decide not to release information verbally or provide copies of records if you believe that the release of the mental health information would be detrimental to the adolescent. So in those cases, you need to document the reasons that you are choosing not to disclose. And I think, again, be thoughtful about this, because if you think that everything is detrimental to share the adolescent, I think that's going to be a problem. That would not be a community standard. That's not the intent of this law. This law is saying we want providers to engage parents and caregivers in the care of their adolescents. So if you had information that you thought was detrimental, again, I would consult with a peer, consult with a supervisor if you work in an agency, and document really clearly why you're not disclosing information. So this is the recommended information that our work group came up with as an example, as some guidelines for providers to use. This is pretty standard information. This is, I think in rare situations, would you not want to share this with a parent, really, because it's all about why the youth, what the youth needs are, their diagnosis, how they're doing, how parents can be helpful, crisis prevention planning, safety planning. These are all very important parts of treatment. So these are the kinds of things you would hear about, that a medical provider, many of these are things that a medical provider would share about their treatment of an adolescent. And so as mental health providers, we should be sharing this information as well. There may be some situations where a diagnosis may not be shared. We certainly see some kids with gender identity issues, and sometimes if parents aren't aware and adolescents share that their parents would not be supportive, that might be an example where we wouldn't share information because it would be detrimental. But many times parents are already aware of these issues and they just need help on knowing how to support their youth. So again, I probably am going to say it too many times today, but it's all about clinician discretion, what is in the best interest or what is not detrimental to the youth. So there's a law, RCW 7002, that has been in place since 2013, but has not been widely used, and that was something that we all kind of became aware of as part of this mental health work group that said already that providers could share information with the youth, their parent, or the youth's attorney. So that law was very basic, and it didn't give any kind of guidelines, and it didn't really talk about clinician discretion. So the information from the work group that we were on has made that law better, in my opinion, because it says still that you can share the information, but again, these concepts of discretion. Providers can also share mental health treatment information with another medical or mental health provider or to make a referral without written authorization by the adolescent. I don't think that's widely known, but that is in the law, so go read your RCW once it's updated. For now, you can read House Bill 1874, and you can see those updates that are being made to that. So if a child comes to the inpatient unit at Seattle Children's Hospital, we can reach out to their treating provider and their primary care provider and talk to those folks without written authorization. We're still experiencing that many community providers are asking for an authorization not required. We're signing them if we have to because we want to be able to talk to them, but please, community providers, look at this information, make sure you understand it and know that written authorization is not required. Of course, we talk to the youth about it. We say, hey, I'm going to call your therapist in the community, but just to let them know. But a written authorization is not required. So we are no longer requiring that and only using it when that's what we have to do to get the information. So I want to point out that for 7002-240, the modifications to law, the parent definition does not include foster parent. So there was all those definitions we talked about earlier. Foster parent is not one of them, but the child's dependent child social worker, their caseworker, does qualify under the definition of parent, but not a foster parent. Okay. So again, protections have been built into this law. If you're an outpatient or an inpatient provider and you make a decision to disclose information, you are not able to be held civilly liable as long as, again, the decision was reached in good faith and without gross negligence. And again, you need to document. So if an adolescent objects, if a parent objects, just document everything, make sure you tell the full story. So we did add a clause about foster parents where we said that the caseworkers, the Division of Child, Youth, and Family caseworkers responsible for the youth can share information with the foster care provider, group care provider under family-initiated treatment. But that does not include substance use disorder records because, again, the adolescent has to consent. Written authorization is still required for schools. This includes anyone employed by the schools, which could include a school-employed counselor or psychologist. Educational age of consent is 18, so we recommend that when you're getting an authorization signed and you want to communicate with the school, and you probably want a two-way communication, that you have both the youth and the parent sign those authorization forms, because the school won't be able to communicate back to you without the parent's consent. But that is still required. I'm going to talk about schools later. The law did not include any past treatment providers. So if they saw someone in the past, they have terminated treatment, and you want to get copies of those records, you do want to have a written authorization completed for that request. As I mentioned, authorization is still required for foster parents for both adolescent-initiated and family-initiated treatment. And then step parents and other relatives or caregivers, authorization is required under adolescent-initiated treatment. So that revised definition of parent only applies to family-initiated treatment, not adolescent-initiated. Okay, lots of information. So let's take some questions.
I heard that there was a question in the chat box, but we're not seeing it. So, here we go. We see some early on questions. This webinar, there will be overflow time until 3, but it's scheduled to end at 2:30. There's a question about the time. And right now, if you have any questions, everyone is unmuted, but I believe you might have to hit *6 on your end to be able to speak. And we are seeing lots of I can hear you.
Thank you. We didn't see her earlier. Oh, there we go.
Okay, so one of the questions we have is, if 3 months passes and adolescent still does not want to participate in outpatient treatment, may the family initiate another 12 sessions or 3-month round of treatment?
Yes. The answer to that is yes, and that's where you may not have a good fit with a person. So just because the adolescent isn't consenting, it doesn't mean that they're not able to engage in treatment with the right provider. So going to another provider is something that families have ability to do. People say, well, what if they take them to 20 providers or whatever? That is a possibility. However, like I said earlier, with the intake and onboarding of a new client, you should be talking to them about what have they done in the past. what was the success or failure, and learning from that and engaging around commonly shared treatment goals that the parent and the youth can share, like, I don't want to do this anymore, and the parent can say, well, here's what we have to work on, and then you as the provider can help navigate through that.
I see a related question about how much time must elapse, if any, between these attempts, and the answer is none. The law did not specify how many times you can try treatment under family-initiated, how much time must elapse between them. There's no guidelines around that. I do want to be clear that you can't repeat the effort with the same therapist, though. Like, you get a one-time with that same provider. If it doesn't work out over the 12 sessions, 3 months, you can find another provider, but not the same person.
All right, we're navigating through because there are quite a few questions in the chat box.
The question about if the family does not evoke family-initiated treatment, you don't have to invoke family-initiated treatment. You are doing it just by being with your child. There is no, I have to evoke family-initiated treatment. If you have a parent in the room, it's family-initiated treatment. The only time it's adolescent-initiated treatment is when the adolescent comes to you without the parent.
Actually, I'm going to question you on that, because I think that that's not been the typical practice. Because again, remember, family-initiated treatment is limited, and I don't think we want to encourage that. So I think if the adolescent, so typically we see kids with their parents bring them to treatment, they obviously know what's happening. That would still be adolescent-initiated as long as they consented. Okay. Because then you don't have those limits put on you that you have to track the number of sessions. It just, right. Our goal is to get the adolescent to consent.
True. Yeah. Both answers. Yes.
Yeah, so we have a question on the phone. Go ahead.
Can you hear me?
Yes, go right ahead.
Okay, thank you. So I had put a question in the chat box, again, not sure if you're seeing it. And actually, I'm really glad you just clarified that point, because I was going to say, all my 13, 14, 15-year-olds who come in here, they don't drive themselves. Parents are there. But if we switch this to parent-initiated, that would be a nightmare.
Yeah.
But the question I had is, when one of our operational managers was looking over the text of the law, you touched on the HCA reporting earlier. If a child is put into inpatient treatment, that then is reviewed by HCA after a certain time frame, et cetera. Do we have to do the same for outpatient treatment? And if so,
no.
I don't see any information regarding who we report to or how.
Nope. Yeah, there's no requirement. We purposely did not put in a reporting requirement for routine outpatient family-initiated treatment, and part of that compromise in our work group is that's why we put in the 12 sessions and the 3 months. So it sets some kind of limit around it, but there is no reporting requirement for routine outpatient. The reporting requirements are for acute inpatient, which is not new, and then the more intensive forms of treatment, which are intensive outpatient programs and partial hospitalization programs.
And this is Liz. I want to put that in with the caveat is that it's not there, but we are hoping to develop a way to track so that we can see if it's effective, how it's impacting the community, if we're seeing a change in engagement based on family-initiated treatment occurring in outpatient settings. So there will probably be information to come on that. And if you're interested in being a part of that upfront, please feel free to email the inbox and let me know.
Mm-hmm. I think, Liz, maybe like a survey that would go out to providers to kind of see if they've been using family-initiated routine outpatient, something like that. That would be like a voluntary participation, hoping to get some good data. Yeah, instead of the reporting requirement.
All right, we'll take, does anyone else on the phone have a question? We have a ton of questions in the chat box. So what we might do is take 1 or 2 more and then move on to the presentation and try to come back to as many as possible at the end. We'll see if we can group some of them together.
I have a question. Oh,
go ahead.
Sorry. Thank you. Hopefully this doesn't get too much into the weeds. And I love what you've been saying about increase parent communication, talk to parents, diagnoses, treatment plans, things like this. There's a part in the new section in the bill that says when an adolescent voluntarily consents to his or her own mental health treatment, mental health provider shall not proactively exercise his or her discretion under 02-240 to release information or records related solely to mental health to the parents of the adolescent beyond notifications required. Does that How does that jive with the you are encouraged to release information as well?
Yeah, so, the distinction was made that when an adolescent has consented, that you just want to check with them first. Proactively means you don't do it without checking. That's all. So you need to talk to them. Hey, I want to talk to your parents about this kind of stuff. Is that okay with you? Even if they say no, you can say, well, I think it's really a good idea to talk to your parents about this stuff, and so I'm going to do it, but I'm going to note here that you disagreed with me. And then you're going to share with the parents what you think you need to share. And again, this is, the challenge that our work group had is that, there's no one-size-fits-all solution for treating all of the youth and their parents in the state of Washington. And so we tried to come up with the guidelines about what to share and how to communicate to youth and how to engage parents, kind of this great juggling, balancing act. And so, again, the big difference is when the adolescent consents, you just don't start off, you don't talk to them and share immediately everything else with their parent. You just talk to them about the process. Do you have concerns about what I can share or not share with your parent? I'm going to listen to your concerns. I'm still going to make a decision about what I think is the right thing to do as your clinician, because I know I need to involve your parents in effective treatment. So that's the big difference. With the other family initiated, you're not required to first check with them. That's the big difference.
Amazingly helpful. Thank you.
Yeah, and I think it's helpful to think about children seeing a provider in a school setting. So the child, if the parent doesn't know that the kid is going in school and the parent doesn't ask for the information, there's no obligation for you to reach out unless you think there's a good reason to do it. It's only if you think, oh, this parent really needs to be involved because that's part of the solution that this kid needs. But it's about giving kids the ability to have privacy if they need to, and especially if there's an abusive situation going on or they are using drugs and they don't want their parents to find out. Well, there's 42 CFR Part 2 that covers that. But it's really to have that autonomy of the kids that are coming without their parents' knowledge, that you're not required to go out and follow up with those parents. I'd like to address that one.
Okay, we have a question in the chat box that says, if MHPs can disclose without consent at times despite refusals from the patient, what is the point of releases of information and the age of consent being 13 years old?
So we purposely in our work group talked about age of consent being 13, and what we heard really strongly was from many community partners, particularly schools, is that if you change the age of consent and require parent consent at older ages, then a lot of kids getting services at schools are not going to get services, certainly not right away, or maybe not at all. So not every parent agrees with mental health treatment. Many do, most do, but not every parent. And so the age of consent remains at 13 because we still want 13-plus-year-olds to be able to access mental health treatment when they need it, whether or not their parent consents. And again, release of information is not required any longer. There's no form for that. It's all about clinician discretion. So we've come up with a system where, depending on the consenting of the adolescent or the family and the engagement of the adolescent or the family, either way, an adolescent can still get care when they need it.
All right, so we have a ton of questions, but we do want to give some time to move on. I see a number of the questions don't ask the question, but they definitely surround a culture shift with how we approach treatment. So I'm hoping that the next few sections will talk to that a little bit and give us some more room for conversation. I will collect these questions afterwards, and we will see what is covered in our frequently asked questions and what we need to develop responses to. Please feel free to email the HCA Family Initiated Treatment inbox at hca.wa.gov. If you have questions that aren't answered, or if you'd like to be on a distribution list as we produce these documents. So I'm going to mute all and head back over to the PowerPoint.
Great. So wanted to spend a little bit of time talking about parent perspective, and parents are thrilled. I mean, finally, that we are improving access to evidence-based care for all. And basically, in a nutshell, this law is threefold. That you can say parent caregivers of 13 to 17-year-olds are now able to access behavioral health treatment without the adolescent's consent. Behavioral health providers may now share mental health information, not substance abuse, with parents without the adolescent's consent. And adolescents can still consent for behavioral health care for themselves. That is it in a nutshell, but there's this huge amount of fine print. I mean, this whole seminar is an asterisk, and I did see a comment from somebody that it feels like you need to be a, highly trained clinician or psychiatrist or whatever you said to follow through all this. True, in one level, the providers, you do need to, update and change your approach. But if you think about the basics, that parents are now able to access the care, that's the goal. If a parent is trying to access care, you are going to try to help them access that care. And you may share information. You don't have to share information. And nothing changes as far as adolescents consenting for behavioral health care for themselves. It's a simple way of saying it, then there's a whole lot of rules behind the scenes. I know there's a lot of parents on this webinar, so we wanted to talk a little bit about what parents need to do in our shift. Sometimes parents are perceived as just wanting to dump their child off and have someone else deal with them. I know that feeling. However, I also know that parents need to be part of the treatment plan, and that by doing my own work, I really help my family heal. And it's been profound change for all of us going through the process. And that's the hope in the cultural shift, is to not just isolate a child, but to be able to really help the whole family heal. However, parents have extreme anxiety. And as a parent who had really serious reasons for my anxiety, it feels very common to have my anxiety treated as like, tut, tut, there. But parents need to have their anxiety acknowledged as real, because we're the ones that live with them. We're the ones responsible for them. But we also need to learn how to manage our fears and know where our boundaries are, and how to respond to those dangerous behaviors, and support for implementing strategies, which can be really difficult. That's why we're coming for help. If we knew how to do this with our kids, we wouldn't be in a provider's office. We want to be involved as allies in developing strategies that help change outside the therapist's office. Family members are the ones that are, seeing the child, have lived with the child, know what has worked, what hasn't worked, and we want to be part of the solution and have our expertise and our lived experience acknowledged. But we also have to understand that it's not acceptable to ask or demand everything, to know about what's going on in the clinical case work. And my feeling is, based on all the parents that I've met in this process, I haven't met anyone that said, I want to know who Johnny is having sex with. I just want to know, what's his diagnosis and what should I do about it, is the level that we're not getting any information right now. We want to be at least able to be effective parents in the process. So we want to be able to build an environment of safety and trust with the provider. And this is a challenge for providers, but I have seen in working with people out of state, where I had one clinician who was working with my daughter, my ex, where we had a contentious relationship, and my son, that person was able to navigate the confidential relationships. You don't have to share everything you learn about every family member with everyone. I mean, sometimes families have no boundaries around information sharing, and providers can help us do that. And one thing I think providers have not understood is, by doing this appropriately around our children's information, you show us that we can trust you with our information as well, and you will get a better picture of what's going on in the home when you build that safety and trust with a parent as well as with the child. We want to remind providers that our child is a dependent, and they're not proven in their ability to live independently in the world. And a lot of the families that are struggling the most with kids who are not wanting help, that's our fear, and we're circling around that we have a child that's not able to even function on any level in their home or in school, and then we need to have them that they need to understand that they're a dependent, and how does that affect them, and how do they move towards independence. That's part of individuation that children go through at this age, and they need guidance in that. Some children are not developmentally able to make these long-term decisions, and there's a lot of brain research that shows, the prefrontal cortex isn't fully developed until you're 25. Well, kids that have ADHD are maybe 3 years behind that. So if you think of a 13-year-old child with ADHD making decisions about, long-term safety for themselves, and they're highly impulsive and about the age of an 8 or 9-year-old or 10-year-old, that's not appropriate for them to be making those decisions, and we need them to understand that as well. And really thinking about that any adolescent is part of a family system, and that families are really affected. Everyone in the family is affected when our adolescent is experiencing mental health challenges. And so there's probably other people in the family that are needing support as well, and that recognizing that is important for all of us. Parents also want their adolescents to know some stuff about us, and providers can help us with that. Parents want adolescents to know we don't want to know everything you tell your therapist. At least most of us, if we're healthy, should understand that that's important. But we also want our children to know that we're looking out for the best for you, even if it doesn't always seem like it. And some things are hard, and you have to really struggle to work through them, but that is life, and it's, when it's in your best interest, it's important to, stick with it and to trust the people around you that are caring and trying to help you. Adolescents also, I know they hear that their brain is still developing, but they may not fully understand that. But they do need to know that, at least I'm hoping that the parents listening know that we have to change as well as the child changing in order to get better, and that we're on board with that, working on our own stuff, and that everyone struggles. This is normal. We want this to, instead of stigmatizing the people who are seeking out help, I think everyone wants it to be something that is not stigmatized, and just because you're struggling doesn't mean that there's something wrong with you permanently, or that you're not human, or you're some subhuman or whatever. You're just normal. So this is like Liz was saying earlier, is a cultural shift, and I put this slide together to just sort of talk about our new cultural roles. There are 4 parts in this equation, including the government. We have been looking at the age of consent as a way of securing that we are delivering kinds of services that we agree with or not agree with, or the child's not forced, for example, to do conversion therapy. In my view, the state is responsible for saying we don't want conversion therapy available, and last year we outlawed it. Yay. So making sure that we're working to have licensing and accountability for system providers is what Liz does all day, and other things too. But the state is also working with public and private partnerships to develop a robust and sustainable system of adolescent behavioral health care. We have a long way to go. The consent and opening up access is a really important first step. I've gone over on some of the things that parents need to know. Looking at a safety plan is one of the things I didn't mention. It's really important that adolescents feel safe in speaking their truth, even if it's something that adults don't necessarily agree with. It's learning how to sit with those experiences and honor them that's important. And clinical providers, we hope that your cultural shift is centering the family in your work, and really thinking carefully about how information is important or not important in the treatment process. And then remembering that, we don't need requests of, or whatever, ROI stand for request of information signed anymore, unless you're going backwards in time to get something in the past. but current providers can talk to each other, parents can talk to providers. The whole double ROIs that everyone is signing that don't mean anything anyway is kind of going away. I don't know about many of the parents. I know those children, my children didn't always even know what they were signing. So the whole thing of signing this consent form was kind of just an extra step that we were doing that wasn't actually always helping in the way that we thought it would. So anyway, so I hope that we're moving in, this will be helpful in thinking about us in terms of the cultural shift.
Okay, so I'm just going to have a couple slides talking about, my thoughts on best practices, and I want to start off by saying that this is going to be challenging as a provider because we are going to be seeing youth who may not want to be there, and their parents have somehow brought them in, whichever means they can use to get them to our offices, but they're not necessarily sure that this is what they want to do. So just because parents can consent doesn't mean youth will engage. We have our job to do, a little bit harder now, to really focus on engagement. And I think the important piece is to start your session off right by explaining why you want to involve parents. This is also for adolescent-initiated treatment. Well, even if they want to be there, they still have to develop trust in this too. So you want to make it a standard part of your treatment to talk about how you plan to engage parents and caregivers, assuming that is a safe decision. Again, there may be situations where adolescents are seeking treatment without their parents' consent, and the parents are not appropriate to bring in. This doesn't change that. You don't have to bring parents into the picture. But this is when the parent has driven the patient to your office and you're going to see them. They're clearly involved. They clearly want to be part of it. So you want to reassure adolescents. You won't share everything with their parents, and then you want to have an ongoing conversation about what's okay to share, when and why. And that can change over time. As new issues come up, you continue to have that dialogue with the adolescent. And what you're explaining is, why is it important? It's important because if parents need to have information about their adolescent's diagnosis and other key details so they know how they can help their youth, which may involve them needing to change behaviors. Just like if an adolescent had diabetes or asthma or another medical condition, parents have to change their parenting behaviors to help their youth. And the same goes true for mental health diagnoses. We need parents to help their youth in the ways that are necessary to help them get better. So documentation. You always want to write your documentation as if it might be shared with the youth, the parent family member, another treating provider. So you want to be very thoughtful about, if you want to document issues that the youth may not want to be shared, you're going to have to be really thoughtful about that. This has generated a lot of discussion where I work about what we're going to do, how we're going to do it, because where I work, we actually have a system where primary care providers can access our records whether or not we know it. So it's not that we actually release to them. We have kind of some shared cloudy things that I don't fully understand that they can log into if it's their patient. So be thoughtful about what you're putting in there. We've talked about adding a statement such as confidential information, do not release. If I have something I really want to document details, but I really don't want anyone else to know about it. And my hope is that if I put that extra statement, that whoever's reading that record will understand, oh, okay, this is a particularly sensitive issue. And then finally, always make sure your clinical notes reflect medical necessity. Why does the patient need treatment? Just because family-initiated treatment, the outpatient treatment is being added under family-initiated treatment doesn't change the fact that you have to have medical necessity for the youth to be in treatment. And then finally, I want to touch back on the school issue, just to again reiterate that you still need those release of information forms for any sharing of information with a school and any kind of school personnel. If the school-based counselor is employed by a mental health agency, you don't require release of information because that falls under the mental health exchange. But if the school-based counselor or psychologist is employed by the school district, they are then school personnel, and you would require release of information. A lot of times school personnel might need information to help the adolescent become eligible for a 504 plan or an IEP. A best practice recommendation is to write a letter or a summary with that specific information. Where I work, we rarely release full records to schools because there might be family psychiatric information or family medical information as well as the youth information, and we want to be really thoughtful about what needs to go to the school. So, but you can always offer to fill out their form, write a brief letter. I've written a ton of 504 accommodation requests over the years to help the youth I work with get services, but provide the right type of information. So, and I always kind of keep in mind HIPAA, which talks about minimum necessary. So I think you want to release the right amount of information to meet the need. So that is the end of that. The next slide shows how to reach me or Peggy. If you have questions for us specifically, we're happy to help talk and share perspectives and answer questions. And I think it sounds like looks like we have about 20 minutes for questions, so that's great. We can start to dig into those chat questions.
This is fantastic. I am unmuting all, so you have the opportunity to participate and ask questions. I will bring up the chat box and we will get to as many things as possible. But you can be, if you raise your hand or if you take yourself off of mute and ask, it's a sure way to get it answered now as opposed to later. So if anyone has any questions on the phone, please let us know.
Hi, I have a quick question. Can you hear me?
Yes.
Great. So if we're working in a school and we are an outside agency not affiliated with the school, if it's student initiated, if the student wants us to talk to a staff member, a school counselor, or a teacher, we would need the parent's consent to do so, or a release of information from the parent because the educational age is 18. Is that correct?
No, so you're a mental health provider working in a school, and the adolescent wants you to talk to the school personnel. You would just need the adolescent. You would need the adolescent's consent to share information with the school personnel. You would need the parent's consent if the school personnel was to release records to you. Because age of consent for education is 18. But you as the mental health provider just need the adolescent's consent to share information with the school personnel.
So without the parent's written consent, we shouldn't have access to anything educational, IEPs, grades, things like that?
That's
my understanding, yeah.
Right, educational records and information about what's going on in the school, consent is 18, so parents have to be involved. But in a school health care clinic setting, the parent does not have to consent and that's adolescent initiated treatment. That's where the youth is on their own acting as an independent person and is able to consent for sharing information within the mental health arena as opposed to the school arena.
So does that mean the adolescent could give consent to have their IEP shared?
No.
No, okay.
That's the school arena. That's not the mental health arena. And you should know this issue that you're talking about is a really tricky one for IEPs and accessing behavioral health care. And there's a work group that Camille Goldie with OSPI is leading on student behavioral health. And I'm going to bring this larger issue forward. I encourage you, if you are in a school setting, to participate there, because there's a lot of questions with children in IEPs and accessing care.
Thank you.
I'm going Liz, just a brief interjection. There are several people who have asked for access to the PowerPoint. So I will try to upload it now to the handouts for you guys to take with you, and we'll make sure that it's available online as well. So I'm going to navigate away from the chat box for a minute so I can make that accessible for you.
So, and while she's doing that, I just wanted to say that if you look at the Facebook group, the YBHA-WA, which stands for Youth Behavioral Health Advocates of Washington, I have a draft one-page sheet that I did for families. It's not officially totally approved, but it is accurate. And it says draft on it, and that is something that you can access now. We hopefully will have that available something similar but very soon that's official from the healthcare authority. But in the meantime, it's a piece that you can use, and feel free to copy and, you know, plagiarize and whatever you'd like. Next question.
All right. If a youth refuses to sign ROI, such as to the primary care physician, et cetera, can the parent sign the ROI for consent of release of information?
So ROI is not required. Under the RCW 7002, 230, and 240, ROI is not required to share information with the primary care provider. So you do not need the adolescent's written release. You do not need a parent to sign a written release. You may communicate with the person they identify as their primary care provider without written release. I do think it's a good idea to confirm with the parent or the adolescent you plan to talk to their primary care provider, but you do not have to get their written release.
And as a note, I just want to refer you back to the page of RCW 70.2, which was the law passed in 2014, which is what that sharing information falls under. It's not part of this specific bill. It's been in place that we have not been following. So that's where that was passed, is part of that. Does that make sense? Okay.
All right, so there's a question, at what point can family-initiated treatment switch to adolescent-initiated treatment?
You can switch at any point whenever the adolescent consents to care. So if you want to do it before the 12th session or the 3rd month, but at the end of the 3rd month, but I think really at whatever point in care it seems like the right time, you just nonchalantly pull out that form, that consent to care form, and say, hey, let's sign the form and let's continue with our treatment. So there's no precise point.
All right. We're moving back up to get some that came in a bit earlier. Can a foster parent initiate family-initiated treatment, or does the Department of Children, Youth, and Family caseworker need to initiate it?
Foster parents cannot initiate family-initiated treatment. If a child is a state dependent, the DCYF caseworker needs to give the consent. Now, a foster parent can bring the child to the appointment. They can bring the child to the emergency department if they think they need an inpatient admission, and it would be up to the provider to make sure that they obtain the consent from the caseworker if the adolescent did not consent. So I'd recommend if a foster parent was going to bring a child for services that they have that conversation with the caseworker in advance, because we'll want to make sure that that provider has access to the caseworker to get the consent. So they can bring the patient, they just cannot be the person that's giving consent. And I'm going to take the one right above it that says, does a step parent need to be legally married or just in a relationship? And it does need to be a legal relationship. So girlfriend or boyfriend, partner, those relationships do not count. A step parent needs to be a legal step parent.
However, you could have the legal parent sign a statement that you are responsible for taking care of the child, which was one of the first categories listed, or sign under penalty of perjury that you are legally able to do this, that you have permission to do this. So there are other avenues in if you're not married in a step-parent situation.
All right. What if the family requests family-initiated treatment and the youth chooses to consent during intake but refuses 1 to 2 sessions in? Does family-initiated treatment kick in then?
Yes, that would be an example of where instead of, in prior state, you would have just had to end treatment because the adolescent revoked their consent, but now under family-initiated treatment, you can continue. And so just remember that that is starting the clock of the 12-session, 3-month period. At whatever point you initiate family-initiated treatment, then you have the 12-session, 3-month period. But yes, you can continue in treatment and continue to try to engage that youth in their care.
And noting that if you are in intensive outpatient treatment, the 12 sessions does not apply.
Right. It's only
the routine counseling. So I mean, I think that in moving our idea about how this works, and that's what I was trying to say earlier, where we had a little conversation, is it's not the family-initiated treatment doesn't kick in. It's like it is. Like if a family member is there, you're in family-initiated treatment. You want to get consent of the adolescent, but it's when the adolescent goes without the parent, that's adolescent-initiated treatment. If you know, you can have family-initiated treatment with or without the child consenting. If the parent is there, if the family is involved, or the caregiver is involved. So it's not like we have to be tracking what category people are in. It's more, how are we engaging, and is it medically necessary? Is there a reason the child needs to be there is the number one question that we should be asking.
Yeah, this is Liz, and I'm going to offer a civilian comment here, but the way I see it shifting is we're going from a move of that individual treatment and moving that individual back into the same environment to looking at a way where we're trying to affect the whole system in treatment so that we can have the most success for a youth. We're engaging that whole system.
Thank you.
It looks like the individual who asked this question has left the room, but I would like to talk about it anyway. Does the federal law prohibit family-initiated treatment for individuals with substance use disorder?
No. Family-initiated treatment applies to mental health or substance use disorder treatment. The only difference is that the substance use disorder treatment providers cannot share information back to the parents without the written authorization by the adolescent. So you can help add them access care, but you're not going to be able to know about care unless your adolescent consents. So it's not a perfect system, but we're moving in the right direction, closer.
But and that federal law is being worked on around mental health care as a whole, because the HIPAA and the 42 CFR Part 2 are not in sync, and there's with co-occurring conditions that makes navigating the mental health system really difficult. It was originally created for pilots and physicians, and now it's being applied to everyone, senators, right? So we need to, look at it. There are people working on it at the federal level. So that's outside the purview.
All right, so the next question is, what happens if you have one parent initiating family treatment and another parent who refuses?
So this is a really sticky situation, and on slide 13 at the bottom, and we'll fix the slides because we kind of had some duplicate information, but on the bottom of slide 13, there was a piece of the law that says if a dispute arises between individuals authorized to act as a parent for the purpose of RCW 7134, 600 through 670, which is the family initiated treatment section, the disagreement must be resolved based on the priority under this RCW 770-065. So I think we might want to, we'll try to get maybe in the FAQs a little bit more detail about what that second RCW describes. But there's basically a process, there's an order of decision making. And so I think for providers, if you have someone coming into you and you know there's a dispute, and this is already the case for adolescent initiated, well, for kids 12 and under, if a parent comes in and says, we have joint decision making and custody, and I know the other, parent doesn't agree, that's to kind of stop the moment and say, well, we got to work this out, because you don't want to get caught in a bad situation between disagreeing parents. So I would not proceed. That would be an okay reason not to proceed. It's not about the adolescent's consent, it's about the parent's consent, and we're not sure who can really give consent. And so look at that law, consult with your legal team or your malpractice insurance people or whoever you have available to help you sort that out. But I would not proceed if I know that joint decision making, or even for, now it's for family initiated treatment if I have two parents that don't agree.
And many providers ask for, even before this law, asked for parenting plans to validate whether you have decision-making ability or not. And knowing that this is a common problem and it can be a reason a child needs treatment, and I've known several families where this has been a disagreement strongly enough that divorce has happened, helping direct the family into focusing on solving the parent problem first, but not saying, oh no, we won't, work with your kid, but like this issue has to be solved. And helping and supporting parents, I have to say, it's really difficult, and and knowing how to navigate that. So you may not be the right person, but being prepared to be able to refer to what appropriate process to manage that is. Mediators, for example, are commonly employed when there's a divorced couple that is really struggling over parenting decisions.
Wonderful. Are there any differences in the law for youth with cognitive disabilities?
No. We talked about developmental issues, and the reality is there's just no way to really make a law that can address all that variation. So the nice thing about this is that you, again, if the youth with developmental disabilities or cognitive disabilities says they don't want to give consent, you can proceed with family initiated. You do have that limit, so at some point it's good to kind of get their buy-in, get their consent later on down the road, but it kind of gives you that flexibility. But right now, the age of consent does not look at cognitive or developmental abilities or disabilities.
No, but that was a strong reason for why we needed to allow parents more involvement. That was because that was a big gap of families that were struggling the most around this law. And I think that looking at the child's disability and their cognitive place and understanding the school relationship, if you're working with that kind of population, super important to figure out what the school connection is. And that's just my lobbyist self advocating, because I think there's a lot of times that there is not that next step, and that often for a kid with an IEP or a cognitive disability knows they have it, and that's part of the issue that they're struggling with, especially as, you know, in middle and high school where it becomes much more obvious.
This is Liz. I have an eye on the time. It's 2:27, and I know individuals some will have to sign off at 2:30. So I wanted to say I appreciate all the participation and give a thank you to Kathy and Peggy for the time, the energy, and the thoughtfulness that was put into this. This is a new law. There are lots of things that are still being worked on and worked out. So we still have some tricky pieces to navigate and solidify. So just know that those processes are continuing. Feedback is welcome. There'll be some more stakeholder groups with some more targeted information sharing specifically for providers and for families. So we do plan on having more opportunities to communicate about this. So thank you for your participation. All feedback is welcomed to continue coming in. With that being said, we're going to proceed with a few more questions and continue to keep sending them as they crop up. And thank you for your participation today. So the next question we're moving on to is, someone asked, can I as the parent share drug use I am aware of with the providers?
Yeah, oh, absolutely. There's always been the ability to share one way. The problem is getting any information back from the provider. I have spoken to providers about this who are in the chemical dependency field or substance abuse disorder field, who said that getting adolescent consent around drug treatment tends to be easier because usually frequently there's a law or school punishment involved. So that's part of what they do right up front. I think there's a big difference between how mental health community and substance abuse community has been handling substance abuse consent. Because when I was speaking to some providers, that's the first thing they do is really encourage sharing of information, because they recognize that that's such an important part. I mean, and the substance abuse community comes out of a long-term history of understanding family involvement and codependency and how the whole family system can contribute to addiction, and no has had that part of their practice for a very long time. So maybe something they more commonly do. But no, you can share anything you want, but without your adolescent's consent.
All right, thank you. Next question. Can a school counselor communicate with a therapist without the parent's consent if it's adolescent-initiated treatment and they have the adolescent's consent?
So I think in some ways this refers back to the schools to determine if they can. So if this is a school-employed counselor, I think that would be a question that you would talk to your school personnel about. It's not addressed in this law. If you are a mental health counselor that is working at a school, well, that doesn't make sense. So it must be a school-employed counselor because you want to communicate with a therapist. So this law does not address that. I think you would want to talk to your school personnel, your school leaders, to confirm what you can share with a therapist with or without the parent's consent. Because again, age of consent for education is 18. So parents typically have to consent to authorize sharing of information.
This is Liz. I'm going to interject with one more thing. There's a question that says, will DCYF caseworkers get training on this new law? And thank you for bringing that up. We'll connect with our partners there and look at what we can provide that can be specific to DCYF caseworkers. So thank you for that question. An additional question, and if the youth is ready to complete treatment and the parent wants to continue treatment, I assume the question is, how do we proceed?
So I'm going to guess that you're under adolescent-initiated treatment contextually with this question, and I think that it's up to you and the parent and the youth together to decide when it's time to end treatment. So I think you would want to just decide, you would want to talk with them and understand both perspectives. I think there are cases where sometimes treatment might shift to more of a parent coaching modality when maybe the youth needs a break from treatment or they've accomplished their goals and the parent still has goals. And so you have options when working with a family to decide what's appropriate. But if you agree that it's time to end treatment and the parents want to continue treatment, I would give them some recommendations about where else they might be able to get some care. So I just think it really depends on the situation. But the law does not address that.
Okay. For the next, if the child enters
Intensive outpatient.
Thank you, an intensive outpatient program under FIT, and they have 4 sessions in a week in that program, would they only attend for 3 weeks?
No. So again, we're going to make a distinction between routine outpatient, which is like once a week, maybe twice a week for an hour, no more than twice a week usually, once a month, every other week, et cetera. Intensive outpatient programs are a different kind of program. They're called intensive outpatient programs. They're typically 2 to 3 hours a day, 3 to 5 days a week. They're billed differently with a different procedure code. So those are completely separate. Those have a different set of rules about when the review happens, which is at the 45 days. After entry, there should be a review. Routine outpatient, there's no external review, but they have the 12 sessions over 3 months. So those are 2 different types of programs.
All right, we have a few questions about, oh, does someone have a question on the phone? Pause for comments. Okay, perhaps there's some background. So there's a question that says, is youth mobile crisis or crisis stabilization considered intensive outpatient? And I think we have some work to do on our end on clarifying some of the definitions of what intensive outpatient is. And that might have to satisfy that question for now, but I would encourage Katie, who asked this question, to continue to ask that, because it's one of the definitions we need to look at and consider to understand how that's going to work together to move forward. If you've got thoughts and opinions, again, I welcome more feedback and comment on that. So thank you for that question, Katie.
And the intent here, I don't know if you're a provider or a parent, but from a provider standpoint, the intent here is to not have barriers to accessing treatment. So this is about increasing access when an adolescent needs it. So if it's a crisis, I suspect that they need it, and if it's medically necessary by the crisis responder, then I would hope that everyone involved would say yes, because this is a crisis, and not allow a child in crisis who's attempting suicide to say, no, I don't want help. Would anyone do that? No. So that would be my hope in all cases. The goal is to protect the child from having information shared about them that would be potentially harmful in their family, like if they're gay and their parents are homophobic. That could be potentially harmful. It's not to, but it's also the intent that families are involved with treatment and having information that they need to be effective in parenting decisions around their kid. And you can't do that if you don't have certain level of information, which were those, I think there's 6 points that we spoke about. So sitting up with the intent, it's parents are able to access care for their adolescents, and providers may or may not, depending on professional judgment and discretion, decide to share information. But the hope is that information sharing will become much more open. I mean, if we remember those things, that will help make a lot of decisions more easily.
I think at this point we're going to take 2 more questions and then wrap up. And then if you have continued questions, send them through, and we will look for a method to respond to that. There's a question in the inbox that says, for inpatient treatment, how does family-initiated treatment compare to ITA, since there is no legal or court order? From that perspective, it's still considered voluntary. So it's definitely not involuntary, and I think, you know, from a legal standpoint, from a court standpoint, it is voluntary, but because it's being initiated by a parent instead of an adolescent. So this is where our age of consent prior to someone being an adult comes into play. So, you know, parents are responsible for their children up until the age of 18, when legally you're an adult. So our ITA laws drop down to 13 because of our mental health age of consent. And so this is just another status. But yes, it would be a voluntary status under family-initiated treatment compared to a voluntary status under adolescent-initiated treatment. All right. And I believe that we already discussed this one, but we can do it for clarification. It just is DCYS. Can they act as a parent? So yeah, on behalf of the under the legal definition of parent already, when a child is a dependent of the state of Washington, then that caseworker meets the legal definition of parent, which will apply to family-initiated treatment. It already does, and it'll continue to apply.
So I have a question. I know that you're going to be posting the slides to the webinar site. Will people who signed up for the webinar who may not have attended have the slides mailed out to them after this, or will there be any kind of sharing?
You recorded this, right?
Right, it's recorded.
Yeah, so we can send a link to everybody, and they can listen to it just as they did live.
Great. So
Perfect.
because about 3 people asked that question.
And for individuals who are still on the line, I know I mentioned it before, I'll say again, there are handouts on there. One includes the slides for today. There is a frequently asked questions about the changes that you can access and that we will post and then continue to update. And just some information about your mental health information and records sharing. So feel free to access those documents.
Yeah. We'll also be posting the video on our website, so you can refer people to it later who might not be on the mailing list.
Great. And I just want to really thank people for their questions and encourage you to continue to send them, because it's helping us update and clarify our materials even further. You're asking some really excellent questions. And I will put a plug in for the Youth Behavioral Health Care Advocates of Washington Facebook group. It's primarily parents, but there are people from the Healthcare Authority involved, and there are legislators that are on the site. And it's a really good way to learn about what's going on around the state. Give feedback and have conversations with other people who are caring about improving our behavioral health system for our children in our state.
All right, wonderful. Thank you all so much. I would appreciate your effort and your energies and your commitment to this, Kathy and Peggy.
Thank you.
All right, thank you guys. Signing off.